So good morning, everyone. Today we're going to be talking about anesthetic care. Yes, we're going to talk about post-anesthesia care. This topic would be appreciated if you had done your rotation in anesthesia, but I'll try to talk about everything you need to know. In case there's something that you don't know, then you'll ask the question at the end of the presentation. So, so we're going to be talking about what happens to what kind of care do you give to the patient. We're not talking about postoperative care. We're talking about post-anesthesia care. So after someone has had their operation, what is essential? What kind of care do we give to these kind of people? It's very important. The immediate postoperative period is very important because it can be life-saving. You can easily die in that postoperative period. At least we've had many cases where people have died because of many reversible causes of death. So the thing is, after you have after the operation, then you have the initial handover. Usually the anesthesia team that has been part of the operation will hand over to the people who are in the PACU. Usually we recommend that the post-PACU, you hear me calling PACU. PACU means post-anesthesia care unit. So the team that is in the post-anesthesia care unit will take care of that patient after that. We usually, when the patient comes in the post-anesthesia care unit, the first thing is they need to have that initial assessment. Okay. When we initially assess the airway patterns because that's very important. Then we check the respiratory rate, and then we check for the oxygen saturation. We look at the heart rate, the blood pressure. If you have an EKG there, you can look at the EKG. The level of consciousness is very important because you want to know if the patient is able. If he's conscious, fully conscious, then you know that the airway is patent. It's one of the things that you can easily do. Then we have other things that you need to check. I would say the vital signs would be the most important. You can also assess the patient's temperature. Patient's temperature is very important in the initial period. Also the presence of pain, nausea or vomiting when they just arrive in the PACU. Those are some of the first things that you have to assess. Considering the anesthesia side, it's also very important to assess the neuromuscular function. And you can use a physical exam or you can use a nerve stimulator. I think you must have talked about it when you're talking about muscle relaxant. They must have talked about something about muscle relaxants. Then also it's important for you to look at those tubes and check for the urine output, the input and output. So you measure it. Then after that, you can start giving them oxygen. Okay. So oxygen is very important, especially for the patients who have been sedated intraoperatively or who had general anesthesia, because hypoxemia is one of the dangers that you have in the post-anesthesia care period. If the patient has had a neuromuscular block, you can assess for the return of the motor and sensory function of the lower limbs. Okay, this is very important because one of the biggest complications for spinal hematoma is a spinal hematoma after someone has had a spinal anesthesia. And this one can be assessed especially after 6 hours, because if someone has had spinal anesthesia, we expect return of motor and sensory function, at least within 6 hours. We have had a case before of a patient who had a spinal hematoma, and that patient was on the ward, and the attendants came and reported to the doctor, the intern doctor at that time, and said that the patient has no motor or sensory function. And this was about 6 hours after the operation. And the intern comfortably told them that the spinal is wearing off. These people were also persistent after like about 3 hours later. This is 9 hours after the operation. They came to report to the intern that the patient still has no motor or sensory function. And the intern said the patient's spinal hasn't worn off, you be patient, and even wrote it in the chat. They did the same thing even 24 hours later. There was no motor or sensory function. They had to call the anesthesia team in after 1 week, okay? Of course, the patient never gained his sensory or motor function. After spinal anesthesia, we expect motor and sensory function at least after 6 hours. If it's not after 6 hours, then you should suspect spinal hematoma, and the patient should be done, maybe a decompressive laminectomy to deal with that issue. So vital signs, after the patient is in the PACU, you have to measure the vital signs. Initially, we recommend the first 15 to 30 minutes to measure the vitals every 5 minutes. This is oxygen. We're talking about the oxygen saturation, the respiratory rate, the blood pressure, the heart rate. So you do it for every 5 minutes for the first 15, 30 minutes. Then you can now measure every 15 minutes and then later every 30 minutes. And this is very important to do in every patient, especially the blood pressure, oxygen saturation, and the heart rate. Okay, so you have to do a respiratory assessment, and because remember that the patient is the main complications that can happen in the PACU in terms of which you need to do respiratory assessment will be air obstruction. Maybe the patient may hypoventilate, so you need to be checking his airway, his breathing, so that he doesn't hypoventilate and then get hypoxemic. And this is very important, especially if someone has been under general anesthesia and he got neuromuscular blockage. Maybe he was given one of those non-depolarizing agents like atracurium, cisatracurium, rocuronium, those that take, rocuronium is short-acting, vicuronium is also short-acting, and atracurium is long-acting, cisatracurium, vicuronium is one of the most, it has the longest half-life on the ones that we use. So you will not even see it being used a lot when you do your rotation. So these are the complications that can cause hypoxemia. Hypoxemia is a very common complication. One of the most dangerous complications in the post-anesthesia period. So this usually is because of atelectasis, which can happen if someone had controlled ventilation intraoperatively, hypoventilation because of the effect of the drugs that have been given, like opioids, which can cause respiratory depression, diffusion hypoxia if you use nitrous oxide intraoperatively. Upper air obstruction may be because of the secretions, laryngospasm due to stimulation of the glottis when the secretions touch the cords. And then, of course, gastric aspiration and edema. The primary edema may be because of the hypoxia itself. And of course, pneumothorax, which can happen every time you ventilate, there's a risk of barotrauma. And then a pulmonary embolism, which can happen depending on why the surgery was done. Surgery is also a risk of coagulation, and embolism can be one of the things. So If patients have been intubated, they can have delayed emergency from general anesthesia. So you have to watch for their respiratory complications, especially if they had neuromuscular blockage, just exchange. And you have to also make sure that they're hemodynamically stable, okay? Hypothermia is one of the issues that they also get in postoperative period. Remember, when a patient is under general anesthesia, or even under spinal, when he's under general anesthesia, the body is not able to respond to reduced pressure. So there's no, because everything is blunted. And of course, if he's also under spinal, and then also considering things that are happening, like the cold fluids that are being given to a patient intraoperatively, and also when they're exposed, like an exposed abdomen, there will be a lot of heat through the exposed abdomen. So they can get hypothermic. They can also get hypothermia because of the effect of it could be the drugs. They could get malignant hypothermia, which can be caused by SACs. SACs is one of the muscle relaxants that can cause hypothermia, and then the inhalation agents, halothane, isoflurane, sevoflurane, etc. So before you think about extubating the patient, you should have adequate oxygen saturation. You should have a good breathing pattern. The level of consciousness, preferably, should be good. It must be above 8 out of 15, but preferably 15 out of 15, and also recovery of muscle strength. This you can check by asking the patient to raise the head. And before you do extubation, you should always be prepared to reintubate in case of anything that can happen during that period. For circulatory assessment, it's important to measure the heart rate and the blood pressure. This should be done, as I said, in the first 15 to 30 minutes. You do it every 5 minutes, and later you can increase the duration when you measure. Then you also have to monitor for bleeding. Bleeding could be coming from a surgical site or any other place. So if there's a decrease in blood pressure, you need to know what is the cause. Is it the bleeding? Is it the drugs that have been given? And then also you have to continue measuring. The patients, when they're waking up, they may be restless. Most of the time, the cause of restlessness when the patient is awakening up is because of pain. Okay, when your patient wakes up in pain, they usually get restless. Hypertension is also a common complication that can happen, especially in someone who has already been hypertensive before. So it's therefore very important to restore the blood pressure after the procedure, and then also resuming his antihypertensives as soon as you can. Remember, beta blockers can be used, calcium channel blockers can be used. You cannot use ACE inhibitors because of their effect on the RAS, and they can be predisposed to renal failure intraoperatively. Okay. So you also have to watch for arrhythmias, okay, which can happen. At least I've seen people get atrial flutters, but any of these arrhythmias can happen. Sinus bradycardia can be because of the anesthetic drugs that you give. If you give a second shot of SACs, they can get a sinus bradycardia. Why would you give a second shot of SACs? Because it's a treatment of laryngeal spasm. When someone gets a laryngeal spasm, especially at awakening, we give them half of the intubation dose of SACs, and this can predispose someone to have sinus bradycardia. So bradycardia is one of the side effects of saxamethonium. Then they can also have myocardial ischemia and infarction, especially the elderly or people who have a history of coronary artery disease or stroke or also hypertension. Okay. So measuring the temperature is very important because they can get hypothermic. Most of the ORs are always they have a lower temperature, and so other patients are more at risk. especially depending on the procedure that is being done. So even hypothermia, I've already talked about hypothermia as one of the things that can happen. Fluid balance is also very important. So you need to measure the urine output and make sure that the urine output is now, postoperative urinary retention is common, especially under anesthesia. So usually the risk factors are because of many things. It could be because of giving a lot of fluids, maybe opioids or anticholinergics. We talked about anticholinergics and their effect, because anticholinergics have sympathetic. It's a sympathetic response. So since it's a sympathetic response, you will get urinary retention. Of course, last time someone asked and said, when you're scared, you're passing urine. And then I corrected it in the next lecture and said that the sympathetic supply is for the internal sphincter and the detrusor muscle. The external sphincter is not under control of the sympathetic, it's under control of the frontal cortex. But when someone is scared, it's because of the limbic system, which is responsible for the emotion. It overrides the impulses that are coming from the frontal cortex, and the patient can actually pass urine. So you need to you have to evaluate the patient who has not been able to avoid to void. Okay, even so, some people, if they're not able to void, what you can do, you can put a catheter, and if the urine volume is more than 600 mils, then you keep the catheter in. If it's less than 600, you can remove the catheter, or you can use an ultrasound scan and see how much urine is actually in the bladder. If the urine is not much, then you can send them home, but you can send them to the ward. If they spend 8 hours without passing urine, then intervention needs to be done. So it has to be after like about 8 hours. So also the neurological assessment is very important, because many things happen. Okay, you can have patients usually can have awareness. Some patients, not all, but they can have awareness with recall following general anesthesia. They can recall whatever happened intraoperatively. They have intraoperative consciousness. So you need to evaluate this in the post-operative, given psychosocial support. So also they can get delirium. Okay, delirium is one of the things that they can get. So here they fail to return to the full consciousness, especially. But this condition, if they get delirium, it's usually temporary, and it usually resolves after 1 hour, 30 to 60 minutes. So this one they can also get visual disturbances. The commonest visual disturbance is a cornea operation. I mean, in ophthalmology, you've heard of cornea operation. So intraoperatively, if there was a laceration to the eye, because when someone is unconscious, the eyes may be damaged. We usually try to protect them, but who knows? Sometimes they can get cornea abrasion, and some people have even reported, but it's rare, partial or complete loss of vision. But this is rare, but it can happen. If that happens, then the ophthalmologist will need to take over. Blood glucose is important to make sure that the patient is not hypoglycemic, especially if preoperatively you assessed and you had the conditions like DM, which can predispose him to hypoglycemia. This is also a big issue in children. So if a patient has an issue, neurological issue, sometimes like if it's a pediatric patient, we actually always give them glucose to solve this. I've already talked about oliguria. So the cause may be because of the operation, and that would be postrenal or prerenal, because maybe they did not get enough hydration, or intrarenal, depending on what the cause is. But you can assess this by assessing the urine output. So you can also have nerve injuries, okay, especially depending on how the patient was positioned, what kind of surgery was being done. If it's a thoracic surgery and is in the left lateral position, it can damage the many nerves. There are different nerve places that can be damaged. Okay. Now, it's important also to assess their pain so that you can treat them intraoperatively, because this one makes the in the post-anesthesia care unit. Okay, so pain assessment is very important. You can use, there are many different rating scales. Okay, these are the two rating scales that you can use, but there are many other rating scales that you can use. So it's important you manage the pain. You can use the non-opioids, but opioids are usually the ones that we use. Those are the common ones that we use. We usually use opioids because they are very effective, but depending on the procedure or the condition of the patient. Now, the most common complication, at least that has been reported by most post-op nausea and vomiting. This is probably the most commonly treated problem in the immediate post-operative period. Okay, it's very important that that you control the nausea and vomiting before you discharge these patients. Most of the anesthesia drugs that we use cause nausea and vomiting, with the exception of propofol. Propofol does not cause nausea and vomiting. It's a very good drug, especially for outpatient surgeries, because the patient will not have nausea and vomiting, no hangover effects. It is common and it has been reported a lot, and it's very harmful. The effects on the patient are quite significant. Okay. So we usually treat it with many things. Maybe to mention that the vomiting center is because of the chemoreceptor trigger zone, and this chemoreceptor trigger zone is in the floor of the fourth ventricle, but it has connection to many things, to the oropharynx, to the GI, to the vestibular apparatus, to the eye, to the pain receptors, to the cerebral, every part of the body. That's why if someone has a GI problem, they can vomit. If the eyes are irritated, they can vomit. If they're in pain, they can vomit. If they have problems with the ear problems, they can vomit. If the cerebral cortex also is involved, cortex is under conscious control. So if someone sees something they don't like, for example, they don't like a certain food, they can vomit, or they don't like a certain person, they can vomit, or whatever is the trigger, that one is part of the cerebral cortex. So now there are many drugs that we can use to do this. Maybe only, I want to also mention that there are some risk factors for the post-operative nausea and vomiting. Of course, the drugs that you use will determine if someone gets post-operative nausea and vomiting, but if someone has had post-operative nausea and vomiting, then he has a risk factor. There are people who are prone to vomiting. You may know some of the people are prone to vomiting, so that will also be a risk factor. Age also may be a risk factor. Gender, obesity also may be a risk factor. If someone recently ingested food can also be a risk factor, even prolonged fasting. Okay, or GI surgery. The GI surgery also is always associated with vomiting. Gyne surgery, ENT surgery, eye surgery, because of course, as we said, ear problems. There's a vestibular apparatus which is connected to the CTZ at the fourth, at the floor of the fourth ventricle. So inhaled anesthetic agents are responsible, and also intravenous anesthetic agents, with the exception of propofol, and opioids also have always been known to cause nausea and vomiting. Some of the other factors that can cause nausea and vomiting would be the pain. I talked about the pain. Hypotension can also cause vomiting. Hypoxemia can cause vomiting, and also involvement of the cerebral cortex, which will eventually affect the psychological factors. So how we manage the post-operative nausea and vomiting is we usually ask the patient to first and then also we avoid excessive pharyngeal stimulation, gastric inflation. We avoid gastric inflation. Usually we do this for our patients, especially in the risky procedure, ENT procedure, gyne procedure, gastrointestinal procedures. And of course, we prevent hypotension, we treat the pain, we avoid the hypoxia and dehydration. Okay. Now, after we have done that, we usually, after we have been in the post-anesthesia care unit, we usually reassess them and now they are ready to leave. Okay. We are back. So we are going to talk about we talked about the discharge criteria, and we said that we're saying that the initial handover of in the post, no, let's go back a little bit. So we're talking about the scores. Okay. So we said once you have done all these things, you have assessed the patient, you have checked his vitals, you have dealt with all the complications, and he's stable every 30 minutes. You have assessed his vital every 5 minutes, and then you started checking the vitals every 15 minutes, and then every 30 minutes, and is stable. That patient is ready to go to the ward. Now, the discharge criteria is designed to determine the patient's readiness to safely leave the post-anesthesia care unit or the PACU. Now, some people use different scoring systems. There are two famous scoring systems. One of the scoring systems is what you see there, and there's another one which is called the post-anesthesia discharge scoring system. You don't have to know the scoring systems, but it's just to know that they are there. These ones are usually based on most of these scoring systems are based on the vital signs, the activity level, nausea, vomiting, pain, surgical bleeding, intake and output, and yeah. Other additional considerations for someone who's being who is going to be put down. Okay. So others that we use to assess if it is into the ward is if then you also have to make sure that the patient has intravenous access before you discharge them. And also, you have to make sure that he's not having urine retention by checking there's absence of bladder distension. Using is greater than 600, then you can leave the catheter in. Okay, so you have to make sure that other tubes are intact. Then, of course, you see the expected volume of bleeding, and you see how much is draining, especially on the incision. So the dressing should be intact. If the patient has had spinal anesthesia, you have to make sure that the patient is able to wiggle his toes or raise his hips as expected, considering the baseline status. Then you should also have stable blood pressures. And then also, if the patient had an epidural, then you have to make sure that the current orders are up to date and are completed. Now, in some cases, the patient may be discharged of more, but if there's a consensus between the team that is handling him, then that would be okay. So the ideal situation is that each patient, before is being discharged, he should be assessed by the anesthesiologist prior to discharge, and also that fully trained nurses should always be available to handle the postoperative patients. Now, so to summarize what we have said from this whole, when we're talking about post-anesthesia care, is that measuring the vitals at arrival when the patient has been transferred from the theater room, the post-anesthesia care unit, which is expected to be close to the theater room to avoid patients getting complications as you're transferring them intraoperatively to the from the theater to the post-anesthesia care unit. So airway patterns, respiratory rate, oxygen saturation, heart rate, blood pressure, if the patient has an EKG, the mental status, the neuromuscular function, the pain, all of them need to be assessed. Even nausea and vomiting need to be assessed upon arrival to the PACU. So after that initial assessment, then you start monitoring them, especially the respiratory rate, oxygen saturation, and blood pressure. And you must on expanding on the period of measurement. Patients who have received the neuromuscular blockage, you have to assess also for the return of the motor and sensory function, which is expected at least 6 hours after, at least maximum of 6 hours after the spinal was given, to rule out things like spinal neurohematoma. Okay, and postoperative nausea is probably the most common. Actually, it is about 25% of people experience postoperative nausea and vomiting after operation. So it's a very common problem. Okay, and then also respiratory and cardiovascular complications are common, and you should try to treat them. The problems like delayed emergency, delirium, visual disturbances, and occasional partial visual loss that happens after operation, intraoperative awareness with recall in intraoperative, they should be assessed also. Now, the postoperative temperature derangements also, both hypothermia and hyperthermia, they can have bad consequences in the immediate postoperative period. So you need to assess them, and you can either warm the patient or you can use pethidine, as you must have had pethidine or meperidine can be used to stop postoperative shivering because it changes the shivering threshold. If the patient is not able to void or he has urine retention, then you can handle that. Okay, and then so we talked about it's important to have a discharge criteria that you follow. And this one, we said it should be based on vital signs, activity, nausea and vomiting, pain, surgical bleeding, and many other things that we talked about. Okay, so do I have questions for this? Do I have any questions?
I think those with questions should raise up their hands.
Yeah.
There's a question in the chat section.
Okay, let me just check chat section. Climbing trees, didn't you leave? What is this? In intubated patients, what are the indicators of inadequate reverse, on how would you manage them? That's a very good question. Now, if a patient has been intubated, I've had they must have told you when you did your when you're talking about muscle relaxant that you can use a nerve stimulator. Now, if you don't have a nerve stimulator, you can use the physical examination, like lifting, asking the patient to lift the head, and so you can ask the patient to lift the head. The head, then you know that actually the patient is to manage but I mean to avoid semia airway blockage, maybe because of the tongue back, because the patient has reduced level of consciousness. All these things are better managed in the post-anesthesia care unit or in the post-anesthesia care period, and this is very important. Okay, do I have another question? Because I have a few minutes, I need to go. Okay.
There are no questions, Doctor.
Okay, Kale, thank you. I think I'm going off.
Okay.
Thank you very much, Doctor.
Okay.